Hi everyone. Hi, Dr. Amin here. Happy Friday. Happy 5th of July. Hi everyone. Good to see you. We're going to talk to Dr. Suzanne Gilbert-Glantz today. She's a board certified OBGYN gynecologist specialist as well as integrative medicine. So that's icing on cake. So we're going to invite her today. Feel free to drop any questions you have about women's health, anything. She's the expert. She's the person you want to ask your questions. I wait for a few minutes here so everyone join us. Send some waves and hearts just to make sure that you're hearing me. So we're going to talk all about women's health today. If you have any questions about menopause, perimenopause, or any concerns, you can always write in the comment or in the question box. So I try to go through all of those questions as much time allows us today. Let me know where you are from today, or where in the world you are now. Hi. Good. So I'm going to... Hi. Yes, you can write any questions you have. Anything, any questions? Hi from Ohio. Any questions about natural herbal supplements, lifestyle? We can go through all of them. I'm just sending invite. Hi, everyone. Hi.
Hi, I don't have a good light. Let me turn. Sorry.
That's okay.
One of those crazy days.
I know.
That's better. I think that's a little bit better.
Every day is crazy.
So nice to be here with you.
Yes, thank you. Thank you for coming here today. It's great to have you.
Great to be here. So let's get into it. I don't know if
Sure.
you already
So,
started talking
yeah,
about who you are or who I am or any of that.
before we start, let's hear you. You just introduce yourself to everyone here, and yes.
And Alessandra is asking what the topic is. The topic is we're just going to kind of freeform about midlife health, basically,
Mm-hmm.
right? Okay,
Yes.
so I'm Suzanne Gilbert-Glantz. I'm board certified in OBGYN. I'm also board certified in integrative and holistic medicine. I'm the founder and author of Menopause Boot Camp, and I'm the chief medical correspondent for the Drew Barrymore Show. And I do a lot of public education. Really, I still see patients part time here in Beverly Hills, but a lot of my focus has been on educating the public, helping to create a dialogue, and supporting their transformation, because there is so much noise and there's so much
Mm-hmm.
confusion, and I think we've gone from a vacuum where women weren't talking about these things, weren't educated about their bodies, didn't understand what was happening, particularly as they entered into midlife, perimenopause, menopause, and beyond. And now there's this amazing momentum, which is wonderful, but there's a lot of misinformation. Oh, hey, Thomasina. That's amazing. Thomasina was one of my favorite, most skilled labor and delivery nurses when I was still doing obstetrics at Cedars-Sinai. But she's moved on also. Um, so so yeah, there's a lot of work to be done, a lot of support to be had. We're still getting quite a bit of pushback, even from I feel like the New York Times. I'm just going to say it, the New York Times in general has been outstanding, and I know you know what I'm going to say, Dr. Bahramini. But you know, really lately they've doubled down on misinformation and acting like the Women's Health Initiative 22 years ago is the be all and end all, when we in fact immediately knew that it was misrepresenting data and really scaring people. So we have a lot of work to do. And then there's frankly a lot of people out there who have opinions, who have a platform, and honestly, I don't know what they're talking about.
I know.
I don't know
Yes.
what they're talking about.
Yes.
So yeah, so that hopefully that answers like where we're coming from.
So you're board certified OBGYN, and how did you end up having integrative medicine? I really am interested to know
Yeah.
that part story.
Well, I mean,
So was it
and
before?
also just to be clear, like it's interesting. I've remained active in educating myself and as an educator in the integrative medical community.
Mm-hmm.
But I wouldn't. I really do practice quite. I practice in a conventional setting. I'm not a functional medicine doctor. I don't identify with that. I'm not against it. I just, you know, I work within that community often. I educate in that community, and I feel like it's very important to bring science that is relevant and as powerful as we can
Mm-hmm.
have, because it's hard to make a comparison between a plant-based medicine and pharma. There isn't the same funding, frankly. I mean, the major funding sources for science in this country are the National Institutes for Health and
Mm-hmm.
pharma. And so if you don't have a pharma product that you're bringing to market, you don't have the same kind of money coming into those studies. How did I get into integrative medicine? I always had an interest in my own self-healing. I was doing yoga and meditation, and just started to get more interested as my patients were bringing information to me, wanted to be educated. And in my book, if you read my book, I think I talk about the person who brought me to Ayurveda, specifically the ancient medical system of India, similar to Chinese medicine, probably 5,000 to 6,000 years old, and what we consider the original lifestyle medicine. You know, everything in that medicine starts with prevention. How do we prevent disease? And it is a total mind, body, spirit, lifestyle, diet, you know,
Yeah.
movement, sleep, sex, all of it is included. Of course, now that's very modern, but the reality is that nothing new is new. It's all based
Yeah.
on indigenous medicine, whether or not we state it. So how did I get interested? I just was interested for myself. I was doing yoga and meditation. Ayurveda is actually the mother science of yoga and meditation. And I had a teacher who brought me this information, and I thought, oh, I really want to learn more. And then it became clear to me that this was a calling, because I saw what was missing in my own education and what was missing in the lives of a lot of my patients, and really being viewed as a whole person, everything about them and how that informed their perception of themselves, or what their problems were, how they approached their problems. And I just felt like, you know, the spiritual aspects don't get
Mm-hmm.
addressed in our conventional medical training, and that's okay. But you know, people are coming to us as whole human beings.
Yeah. Yeah.
The other thing that I always like to talk about is that there's this weird, I mean, blind spot, if I'm putting it kindly. I think when I'm in a more confrontational, provocative mood, honestly, it's colonialism, it's white supremacy, it's really a dismissal of indigenous medicine and an erasure of indigenous medicine. But the reality is that probably conservatively 30% of pharmaceuticals come from the plant world. And that didn't drop into the brain of an academic physician or scientist.
Yeah.
That comes directly from indigenous medicine.
Mm-hmm.
All humans have always existed on this planet in harmony with nature, mostly, until us. I mean, you know, seriously,
Yeah.
really.
Yeah.
And we're paying the price. But those plants that were local to us were what we used and discovered as medicine. And they are medicine. So that's the other thing, like just from my science brain is really interested in why does this work? How does this work? How can we employ it in our everyday lives? So that's a big love. I grow a lot of herbs in my backyard, which I make medicine from. I live in Southern California. Things like oregano, rosemary,
I see.
lemon, they grow. Brooke,
Wow.
trying to listen, Brooke. That's my nurse practitioner. That's my colleague. We work together. She's she's the bad influence. um, no, but I grow things and I make things. You know, I make oregano oil. Very easy to make. Very has lots of science on antimicrobial and pain
Mhm.
management properties, and it works. You know, you have a burn, you put it on there, it helps. So I could go on and on.
I
That's
know.
my love. That's my love. Somebody's asking about finances
Yeah.
that are not covered by insurance. Well, first of all, I do take insurance right now, but yes, you're right. Medical system is in
Yeah.
disarray. I don't think we have time for that one today. That's
No.
a sad one.
So one of the very common questions we have is about women who are still having normal cycles, very regular cycles, but they're perimenopause before having their menopause and stop their cycles, but they have symptoms,
Yeah,
sudden onset of symptoms. So first of all, how to diagnose this is just due to hormone
right,
changes and not other things like sudden onset of depression, palpitations,
right, right.
tired, fatigue, weight gain. So those symptoms first, how to be labeled and say or diagnosed with perimenopause. What
Yeah.
you normally do in your patients, how you.
Well, it requires a conversation, and I will reframe with language because language is important and it's powerful. And I mean, I use the word. I don't want to criticize you, but I want to be clear. You know, it's not really about diagnosis. It's because perimenopause is a natural state of being, and so is menopause. And I know you practice the same way as I do, but I really want to point this out to the people who are listening because it's not, you don't have, there's nothing wrong with you. It's just that things are changing and there's discomfort. So two things, you're right, we want to exclude that there is another medical reason. We want to exclude that you don't have,
Mhm.
haven't developed a mood disorder. You don't have a new onset or a worsening of your, or a flaring of an autoimmune disorder,
Mhm.
or a thyroid disorder. There are other things we need to make sure are not that. And I think if we have excluded those things, and that's for a discussion with your practitioner,
Yeah.
which requires that they take the time,
Mhm.
but also requires that you advocate for yourself. And I'm going to give you a tip on that when I finish answering this specifically. You know, when you're having those regular cycles, and let's say you're late 30s to mid 40s, late 40s, and I would say start tracking, use a cycle tracker, and don't track just the bleeding, the duration, the amount, the quality, and the experience. Track your bowel movements, track your sleep habits, track, are you starting to have night sweats, especially the week before your period or from ovulation on? Are your moods much more sensitive? Is your joint pain worse? Is your fatigue worse from ovulation to menstruation? I mean, that's perimenopause. And that's classically what we see first. The two things I see before people are tracking a really significant change in their cycle are mood stuff, or like what I call PMS on steroids. Just like maybe you had no PMS and now you have 10 days, or maybe you had 2 days and it's 7 days. And it's everything from all of the above, breast to every month. I did it in my late, I'd be like, am I pregnant? What is going on? You know, I didn't even understand that.
Mhm.
That's due to the changes, not just in your estrogen level, but your progesterone level. So
Mhm.
as your egg quality is declining, as the ovarian reserve of the number of eggs is declining, progesterone is produced after we ovulate in order to support a potential pregnancy.
Mhm.
So it's not just estrogen. I think people get really hung up on estrogen, but progesterone starts to decline actually quite rapidly. And that mismatch is responsible for a lot of the symptoms that we see. The other one is um, dryness, vaginal dryness. Genitourinary syndrome of menopause appears in like 15 to 20% of women before any other change.
Mhm.
So, and honestly, I'm just being honest, like I've seen it with my patients. I had it too. Like all of a sudden I had a little more dryness and irritation with sexual intercourse. You know, just like why is that hurting? That never happened before, you know? So those are two of the things that people can watch out for. And then in terms of advocacy, a couple of things. If you're seeing a practitioner for your annual and they take insurance, be realistic. This doctor only has so much time. And by the way, they're not getting paid for anything more than what you set out to do. So if you want to have a conversation about this, make an appointment separate for this.
Mhm.
Or bring it up and see if they'll talk while they're working, or bring it up and say, like, hey, these are my two priorities today. Doc, can we do this while you're doing the PAP and the breast exam? Or or can I come back?
Mhm.
Like, you are a grown up. You have to navigate this system. And you have to understand that your doctors are really under the gun. It's not, we see a lot of doctor bashing, I think, online, like they're gaslighting us and we don't get educated. And all of this is actually true. But I think one of the things that we got to work together.
Yes.
We're a team.
Yes.
So if you come to me and you are a little more organized in your thought process, or you even say like, I'm really suffering, I don't know what's going on, can I make another appointment? Because I do this, I give you homework. Okay, you're gonna get a cycle tracker. I want you to come in 3 months. You're gonna look for this, 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 and this. Like, you might get more help than you realized, or you take, save this conversation for later. Take notes, bring it in.
So just to recap, is to know your body well by start tracking your changes, your sleep, your periods,
Yeah.
ovulation, your mood,
Yeah.
PMS. So by
Get to know, we do so much and we are so discouraged from knowing ourselves, honestly, and from being in our bodies, especially as women. There are a lot of messages about that actually encourage dissociation from your body. And the interesting thing about perimenopause is that your body is going to get your attention, whether or not you want it. So sometimes discomfort is a way of your body saying, hey, could you please pay attention to me? I need some help. And I think maybe we reframe this a little bit as an opportunity. It's an educational opportunity. Doesn't mean it'll all be fun. We do want it to be supported. That's why doctors like us have these conversations. This is a doctor who's done lots of training and you've devoted your career to this. You do all this free content. You spend a lot of time doing it. Exactly. So there are ways to get information, then get to know yourself, and now bring it to somebody who you can partner with.
Yeah. No, I totally agree.
Yeah. Yeah.
So there again, in my practice, I see women, in some cases, we do start some hormones even before they go through menopause. But
yes. Absolutely.
A lot of times. Then my question is about women who are not that keen to start hormones before they go through menopause. So what do you know? Do you have any experience seeing those women, and what are your recommendations to those women to how to help themselves?
This is where the integrative medicine and the plant-based medicine really comes into play. Often I will refer for patients of mine who have had any experience with acupuncture or Chinese medicine and have a person that they've worked with, that if that person does know more about this is a great time to return. And I really ask people to think carefully about kind of shotgun, like the people come in and want a list of all of the supplements and things that they should take.
Yes.
And I stop them and let them know, like, with the exception of a couple of things that I think we all should be doing, omega-3s, vitamin D, magnesium, that's not how a holistic integrative approach works. We have to understand what's going on with you. And I think if you're going to go see an outside practitioner, like, I don't think you should be doing herbs with me and herbs with them. And, that's, what are you doing? Like, again, it's all about paying attention and being a little bit more embodied. Having said that, some of my favorite herbs for this particular period of time are Vitex or chasteberry. Really, really interesting clinical data on kind of helping to manage that crazy PMSy perimenopause, really the physical and the mood symptoms. Again, we think it's doing a bunch of things. It's probably having an impact on the GABAergic system, but also possibly on progesterone production, which is, makes sense, right? So that's one of my favorite ones. Any of the herbs, a lot of them are phytoestrogens, meaning they are plant-based estrogen-like molecules. Some of them are not. for things like the hot flashes or night sweats. So black cohosh, which has been maligned and really for no good reason. There were some case reports 25 years ago about liver toxicity. That doesn't mean that the herb is unsafe. It means that that person got something that wasn't highly vetted, really clean, or was overusing it, or may have had another problem. I mean, a case report is not, we don't change practice based on that. But that has persisted, and I've seen other experts saying like black cohosh causes liver damage. No, it doesn't. No, it doesn't.
I
A
still
person had liver damage.
on it.
Tylenol causes liver damage.
Exactly.
And Tylenol overdoses happen far more frequently than black cohosh. So let's like calm down. But again, this is about, I think this is really like this weird racism that we don't identify with. I'm sorry, that's what I think it is. That's my opinion. This is this white lady's opinion. So black cohosh is really interesting. Siberian or Russian rhubarb, it actually looks like it acts like a SERM, a selective estrogen receptor modulator. So it's pro-estrogenic in the brain and the bones, and the brain is essentially where the hot flashes are coming from, but it's anti-estrogen at the uterus and the breast, which is really interesting. Again, the data on this, these are smaller studies, but they're very interesting. So there's a whole, red clover, the soy isoflavones, those are good. Pycnogenol, which is French maritime pine bark, is really interesting for hot flashes specifically, but also has a lot of other, it's an adaptogen, so it's very stress relieving. We can get into all the stress ones: rhodiola, ashwagandha, passion flower, for sleep, jujube. I mean, I could go on and on. There's a lot of interesting things that we can be doing to support our health and our lifestyle, because again, we want to, like you said, get to know our body, understand what's happening. We always want to support our sleep and our stress, as much as is humanly possible. And then we can look at how are we layering in specifically lifestyle modifications or herbs to help support us being more healthy as we head into the sunset. I mean, we don't have long-term health data. In other words, we can't say that osteoporosis or dementia or heart disease are going to be seriously impacted by these herbs. There's no way. We're never going to have data on that. We have a hard enough time talking about hormone therapy and those things are game changers. We know that. The data is there, but they can be used safely together. And I think when I have a patient, like you said, who wants to be more natural, or maybe they have a medical issue that concerns them around this, then this is a good option.
Yes, that's great.
And it's a good bridge. I find it's a good bridge. A lot of my patients, honestly, will start with this, and then they get to a point where they're like, okay, give me the hormones.
That's true. Someone is asking here about acupuncture. You mentioned acupuncture, and how frequent acupuncture you recommend.
I'm not an acupuncturist. I am not a doctor of Chinese medicine. This is what I tell my patients who are pursuing that. If they're local, I have people that I've worked with for years that I think are excellent practitioners. And just like people do it, but I wouldn't expect your nutritionist or dietitian to tell me how to deal with your ovarian function, although they sometimes do tell me what to do. And I wouldn't tell them how to practice. I can't tell you what they would do. That would be their conversation with you.
Okay. Now we see again another common presentation is weight gain or changing body composition during perimenopause. I mean, I noted in myself, just like one night you wake up in the morning and you see sudden change, weight gain around abdomen and chest. So first of all, what are the reasons for people who not know? And secondly, how you normally deal with it or treat this problem or recommendations?
I mean, this is a complicated thing. Can you hear that noise, or it's not hearing it? Because my partner just came home and is on the phone. And hold on, please. Babe, can you, I'm on live. Can you just turn the water off? This is what happens when you do things from home. So sorry. Okay. So weight gain drives people crazy. Look, our metabolic rate changes. It's harder to build lean body mass. We start converting to fat. A lot of this it's real. Nobody's making it up. Although the data does seem to show, and I don't get this, I'm thinking it's averages or something, that there isn't like really a big weight gain. That isn't it's that there's a weight redistribution. That's not my experience, and it's definitely not what I see with my patients. I'd love to hear what you see, but that's not my experience. Having said that, I think the stress level, the sleep disruption, and the sort of, you can't get away with anything anymore. I would really like to, again, reframe in terms of being in your body and being healthy and focusing on health.
Yeah.
So, you know, we know that as we start making less ovarian hormones, the cholesterol precursor is still hanging out. And so your cholesterol goes up, right? When people are like, I don't understand, I didn't do anything different. Why is my cholesterol 40 points higher? Well, because there's cholesterol, which is a precursor, not being made into estrogen and progesterone anymore. I mean, it's just math, right?
Yes.
But this is also what is driving diabetes, heart disease, things like that. If you had a pregnancy and you had a complication in your pregnancy of gestational diabetes or any kind of hypertensive disorder, preeclampsia, gestational hypertension, you know, before, during, or after, some people will present after they have birth, you're at much higher risk for cardiometabolic disorders as you age. I mean, much higher. So type 2 diabetes, you know, hypertension, heart disease. So we really need to double down on our sleep, our stress, our movement, and our diet. And, you know, hormone therapy has been shown to sort of aid and abet those things. I think how that works is not that it's fixing it. So hormone therapy is not a weight loss drug.
No.
I think what happens is you feel better, your sleep improves, your mood is better, you have more get up and go. And so that helps you be in the lifestyle. But we have to be getting a lot more protein. We have to be heavy lifting. We have to dial back the high intensity exercise. That's actually not good for us. We want to do a lot more zone 2 cardio. I saw somebody on here who's laughing because I just did a retreat and we talked a lot about zone 2 cardio. And we have to really be looking at all of the aspects of our lives. We also have to love ourselves. You know, our bodies are going to change. I think the GLP-1 agonists are really, really interesting. They're not a silver bullet. I think for people who already have, you know, metabolic disorders are on the road. First of all, I want to say I'm not judging any decision. I feel like when people have 10 pounds to lose and they're doing it, I'm a little concerned because if you don't change, I'm a lot concerned actually. If you don't change your lifestyle, it's not going to be long lasting. And, you know, so that's just something to keep in mind. But I think learning how to love ourselves enough to take care of ourselves and focus on our fitness level, our strength, our flexibility, our health. If you follow our colleague Vonda Wright, I mean, I think she posted it in the last couple of days of her doing a squat, a deep squat, but nothing, just like doing something, not a weighted squat. You know, she's an orthopedist. She talks a lot about musculoskeletal health. And we know that the skeletal muscle is super important for our metabolism. If you want to lose weight, you've got to focus on skeletal muscle health. But there's also flexibility, right? Because you want to have longevity. You want to prevent the trip and fall that results in a fracture and an increase in mortality, right? So things like squatting, flexibility, something called get up and go, the amount of time it takes you to get up either from the floor or seated, stand straight and walk, that's actually related. There's plenty of science on that and longevity, right? Because if you're 79 or 85 and you can get up by yourself and walk, you're not the person who's going to trip and fall in the night when you have to go to the bathroom. You're the person who's going to notice the root sticking out of the sidewalk and change your gait. You know, you have to course correct. You have to be flexible. It's a message across the board as we age.
Yeah, interestingly, I was just recently to a big seminar, and it was talking about longevity and exercise, what is good for us. And studies should start with at least 8,000 steps daily. That itself, it's great. And also combine that with strengthening and training. More of a compound movement rather than one joint to have a few joints at the same time. Great. So that's
functional movements. We also know that, look, dementia is much higher, more commonly encountered in women. And I think that Lisa Mosconi's work is really showing what we thought, which is that it's related to estrogen loss in the brain. But things like walking, I think 3 times a week for 30 minutes a session decreases your dementia risk by like 25%. So the blood flow, I mean, it's common sense. Get the blood flowing to your heart, to your muscles, to your brain, and you're going to do better, to your digestion. Like a lot of this is common sense. I think we've just like, again, dissociated from our bodies so much that we don't know what we're supposed to be doing.
Mm-hmm. That's well said. Amazing. That's so good. So what about, I mean, we get to the juicy part or ugly part about this hoo-ha about breast cancer and
Yes.
relational link to hormones. Still in this day and age, people, even doctors, worried about
Yeah.
prescribing hormones and link with breast cancer.
Yeah.
So any thoughts or talk about this?
Yeah, definitely. First of all, I'm a breast cancer survivor and I'm on hormone therapy. Okay. I'm 11 years breast cancer survivor. So I've finished my treatment many years ago. I had early stage breast cancer and I was young when I had breast cancer. These are all factors that led to my decision. But again, our wonderful colleagues, Dr. Avram Blooming and Carol Tavris' book, Estrogen Matters, if you don't know about it, you really should. They have really debunked and debunked the notion that hormone replacement therapy causes breast cancer. Without getting too far afield or too into the weeds about it, basically, the Women's Health Initiative was looking at women who are a full 10 years older than the average age of menopause. So using them as a demographic to look at how does hormone replacement therapy affect our long-term health doesn't even make sense, because this 10 years or more later, some of these women were 70 years old. Their risk of breast cancer is way higher than a 50-year-old. So if people don't know, there's all the things you bring to the party, but age and having breasts and being female are the top 3 risk factors. And every year you're alive, your risk actually goes up quite a bit.
Any other cancers, not only breast, so any
100%. And that's a whole conversation in of itself, because I feel like this unholy fear of losing breasts is more about, honestly, like our own value and self-worth. I'm not saying I would want anybody to get breast cancer. I had it. It's not fun. Okay, I don't recommend it as an experience. But I do think this like fear of breast cancer, your lifetime risk, spreading everything out, is like, 1 in 9. Your lifetime risk of heart disease is 1 in 2 or 1 in 3. I mean, we're just worrying about the wrong thing. Like, our boobs are not everything, okay? That's not like, love boobs, but like that's not the most important thing about you. And actually, most breast cancer survivors are going to be diagnosed early and going to die of heart disease. I'm going to say that again. This is another reason why we need to look at hormone therapy in early stage breast cancer survivors. They're more likely to die of heart disease. So we know heart disease risk is reduced by using hormone therapy. So if we take a 40-something-year-old survivor and now we're increasing her risk even more, is that really, and we're probably not increasing her risk of recurrence or death. Even the data in the Women's Health Initiative showed very clearly, and this is not hormones that you and I probably use anymore. These are hormones that were being used 25 years ago. That the increased risk was less than 1 per 10,000 users of hormone therapy. That's not really significant. And furthermore, it looks like it was the particular type of Provera, which almost nobody uses at all for any reason for long term, is probably the bad player. And the women who were not using any progestin, so not bioidentical, not identical to your body, but progestin, which is what they used in this study, women who only were on estrogen because they didn't have a uterus had lower risk, like a 20-something% lower risk of breast cancer. So if you're confused, you should be, because I don't understand why the message was, this is giving women breast cancer, stop. It's not accurate. It bears a big conversation. So if you are a breast cancer survivor, you're not going to go out willy-nilly. You need to find somebody who understands what this data means and how it applies to you. If you have a family history of breast cancer, honestly, unless you are a carrier of a gene, which is a whole other conversation, your risk is elevated. But adding hormone therapy on top actually doesn't elevate it any more than that.
No.
We have to educate our patients and stop scaring them. Our colleagues, this is where we really have a big problem. Our colleagues are still misquoting data. Yeah.
We will get there.
Yeah.
It takes time.
Yeah, slowly but surely. I will tell you, in my community, people refer to me now. I'm finding that the breast cancer doctors at Cedars and UCLA, they're not going to prescribe it, but that's not their job. But they're fine with it. They're fine with it.
That's good.
Yeah.
That's good.
Yeah, it's
That's very
interesting.
positive. Yeah. 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 So what about, again, very, very common presentation or symptom of menopause, vaginal atrophy. Um, and I still have some women who are scared using estrogen, vaginal or topical estrogen,
Yeah.
as vaginal estrogen. So first, what is vaginal atrophy, and how you normally deal or treat this condition?
So that's really just referring to the changes that happen in the tissue of the vagina, the vulva, the urethra, and the bladder. So a lot of people now refer to it as genitourinary syndrome of menopause, although it can happen for other reasons if you have a declining estrogen level, like postpartum, or on another medication, like if you're a breast cancer survivor on anti-estrogen. The tissue thins, the pH changes, the resilience decreases, we have less collagen and elastin. We have a change in the microbiome, and that sets us up for discomfort, pain, infections, or feeling like we have an infection. It's just inflammation often. These are things that are not just uncomfortable. This is not just about sex. This is about your health overall. And topical vaginal estrogen, there's also one product called Prastrone, which is another, it's DHEA, which gets converted to estrogen or testosterone. These are all local therapies. They are not going to go into your bloodstream and go through the rest of your body. So consequently, they're not going to have any positive or negative impact on the rest of your body. They are in the vagina, vulva, urethra, bladder only, and they're very, very, very safe. There is nobody who can't use this. You could have a stroke, you could have blood clotting disorder, you could have cancer, you could have a heart attack. These are things that might exclude you from using systemic hormones, not vaginal hormones. And again, it's personal comfort, but also health, especially when we're talking about the bladder and the urethra, because if we're having more urinary tract infections, we're setting ourselves up for kidney infections, for sepsis. As older people, really, we can get into a lot of trouble. People can die from that. So it's not just about sex, although I think sex is really important for a lot of people. So this is something to really understand. It's, again, I mentioned 15 to 20% of us will start having an experience of this well before our periods really change. And there, anytime you're having symptoms is the time to have the conversation and start medication or some kind of therapy to assist. It's really, really easy to do, very inexpensive, and you know, just should be offered pretty much to everybody as far as I'm concerned.
Yeah, I agree, 100%. Someone was asking, do you measure hormones when you start hormone
Nope.
replacement therapy? Do you measure estrogen levels afterwards in serum to see
No.
if this is a normal range, or if the optimal range, or no?
There isn't
Batch
really
two,
good, there isn't really, there's not good data on what is optimal. I hope that we will have that at some point. We
yeah.
just don't have that data. So again, we're talking about replenishing a supply that is diminishing as a progression of natural physiology, right? So we don't have a reference range. And if you have a doctor who's continually testing you and changing your doses, and you're spending a lot of money on compounded hormones, which I'm not against compounded hormones, but that shouldn't be the starting point. You can get bioidentical, you know, FDA approved, safe, highly vetted hormones from the pharmacy, from a prescription. You know, I think compounding pharmacists are fantastic for someone who has an allergy or needs a different dose or can't, you know, swallow, whatever it is. And for testosterone, which I think we'll end with that because then I'm going to have to go. But, you know, hormone therapy is based on your clinical symptoms right
Yeah.
now. I'm not saying that I never do testing. I think if somebody's having like really weird reactions and we can't figure out, maybe they're metabolizing different, or if they've come to me with these hormone pellets, they get very, very high doses. I do want to see where their numbers are so we can bring them gently down to a normal range that isn't going to cause problems. We do know that super physiologic doses, very, very high doses, can cause complications and problems, not just in side effects, but in your health, vaginal bleeding, all sorts of stuff. But generally speaking, that we don't test. We don't test. And
I
that's a
think
big red
I
flag.
knew. Just sometimes patients come to me, so especially the symptoms is one of the first things. So we see, okay, the vasomotor symptoms stop, no more hot flashes, great, but they're asking more as a prevention of osteoporosis, for
But we don't
example.
know
Is this
the numbers on that.
yeah?
I mean, I
So
wish we did. I hope that we will have those numbers. You're right. We don't know what is the optimal number for dementia prevention, for osteoporosis,
mhm.
for heart disease. We do not know that. This is a problem, and I think there will be a time when we will be checking people's levels. But right now, I think we're probably doing the same thing, which is like, if your symptoms are better, we're going to presume that this is having an impact on your body and your specific physiology. It's frustrating, and it seems weird, but it is the science. And the other thing is that people, it's not like when your estrogen falls below here, you have a hot flash, and when your progesterone is over here, you have breast tenderness or itchy ears, or what. We don't have any correlation between specific symptoms and specific numbers at this point. So until we do,
Yeah,
we're not
we
doing that.
we are complicated. So
Yeah, we are complicated, but also we're complicated partly because nobody's studying us.
I know.
I mean,
I
I don't know. We'll see.
bias.
Well, I think it'll be interesting to see what's going on in 20 years.
Yeah,
I'm hopeful. I'm
yeah.
hopeful.
I
Yeah.
am
Yeah.
positive and hopeful.
Yes. Let's,
So
do you want to end? I know people wanted to know about
testosterone.
testosterone. You want to talk a little bit about testosterone?
Let's
I
do
feel
testosterone.
like testosterone is the next, just the next frontier. And
I
that's,
really like testosterone.
so do I. And I have to say that my thinking about it has really evolved as there's been more data.
Mhm.
We know that, there's a position statement. Okay, so first and foremost, for those of you who don't know, the FDA does not approve use of testosterone for women for any reason. Now, we do, all of us in clinical practice, do something called off-label use. In other words, the FDA approved a medication for this use, but we know that it works for that use, and we all do it, and everybody does it. We do it with antidepressants. We do it with misoprostol for induction of labor. There's lots of, this is not like some weird outlier thing that we do.
No.
The preponderance of data on arousal disorders and hyposexual disorder for women with testosterone is there. And so for that reason, the Menopause Society and International Society for the Study of Women's Sexual Health both recommend evidence-based uses of testosterone in women. So it's available for women, but it's hard to get. So this is where compounding works well.
Mm-hmm.
I also now am seeing more sources for testosterone for men, and we know that we dose it essentially a tenth of the dose for women, right? So there are gels and things like that. So great for sexual health. The truth is, I think there's a lot of robust data on musculoskeletal syndrome, right? Bone strength, sleep, interestingly, mood, because we have testosterone receptors all over, just like we have estrogen and progesterone receptors all over.
Yeah.
So
Brain.
I think, yes, the brain is a big deal. So the sleep, the cognition, the mood, I think we're going to see more and more use of it for that. And I am starting to work more with my patients on that. We get them kind of leveled out on estrogen and progesterone, and then we talk about adding in testosterone. Or a lot of times they're younger and they don't really need the estrogen and progesterone yet, but they're really noticing, especially the sexual health stuff. So I think we really need to be talking about this. I almost always use transdermal gel or lotion. I have a couple of patients that prefer injectable. I don't know why. I think they get a boost of it and they feel good. Pellets, we touched on, that's a no for me. A pellet is a little rice grain sized, literally pellet that has testosterone or estrogen and testosterone, usually in a fairly high dose. It's surgically inserted into your buttock, and it lives in there for however long it takes to wear off. The problem is you can't control that dose once it's in there. I see people coming in with very elevated doses, 10 times the normal range of a young adult. And believe me, they don't feel good. They have a lot of side effects, or they have, like I mentioned, I've had people coming in with bleeding and all sorts of problems.
Yeah.
It's not like you can't get testosterone another way. Like you can get testosterone that's going to work in a way that you have a lot more control over. So for me, until the pellet people do more research, it's a no for me.
Yeah, because people I've seen coming to my practice, they have highs and then very low. Suddenly
Yes.
they dip after like
Yep.
a few weeks.
Yep.
So it's so up and
Yeah.
down, not very healthy.
Right.
No.
Yeah.
Mhm.
Yeah. Yeah. I
Someone,
agree.
if you don't mind to ask the last question
Yeah.
here, someone is saying I had ovaries and fallopian tubes
Yes.
out for family gene. I'm 65. I'll be experiencing the hormonal problems, even though I'm full menopause, taking Vagifem 3 times a week, which really helps for dryness. So, okay, that's great. I didn't get any questions. Someone, I think, is just,
Kind of
yeah,
talking about their
yeah,
experience. Yeah.
explaining. Okay, that sounds
Yeah.
very good. You
And I mean, I will say with people who have what we call previvors, people who have some of these mutations and they have these preventative surgeries, again, depending, I'm not giving medical advice here, but a lot of those people are candidates for systemic hormone therapy,
Mhm.
actually. Um, so I think people need to keep that in mind. I mean, at 65, already done with the surgery, I don't know that I would start somebody on anything at this point. And I don't know that she's asking that question, but I have a lot of patients who come in, and I'm sure you do too, in their 30s and 40s planning for these surgeries. And many of them really are candidates, not just for the vaginal estrogen, but for systemic hormone therapy, especially because if you're going to lose your ovaries at 40, that's a lot of estrogen you're not getting for your brains, your bone, and your heart. And we want to balance, it's called shared decision making. We want to balance the risks and the benefits. Everybody gets to get the information and then make a decision. And the other thing that I borrowed this statement from our friend Kelly Casperson, starting hormone therapy is not an amputation. In other words, you don't like it, you change your mind, you can stop. It's
Exactly.
not
Yeah.
irreversible. So let's like power down, get the
Mhm.
information out there, partner with a practitioner that you feel like you can have a conversation with, use people like us as a resource,
Yes.
advocate for yourself, and do better. We'll all do better this way.
All very good advice.
Yeah. I'm so glad we did this. Thank you for inviting me on.
Thank you. It
I
was
love talking to you and meeting you. Hopefully I'll be meeting you in person at some point
hopefully,
soon.
hopefully lovely to meet you.
Oh,
Have a lovely
same.
weekend. Enjoy
Yes,
your weekend.
everybody have a beautiful weekend. So nice to see all your little numbers on there and your questions. And thank you so much for having me
Great.
on. All
Good to
right,
see you.
take it easy.
Thank you. Bye-bye.
Bye.
Bye.